morning. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to introduce you with the evidence-based medicine theory and the practice. My presentation will be divided into 5. First, introduction, why is EPM, what is EPM, and steps of doing EPM, and I will be concluding at the end of my presentation. Well, you may know this from the newspaper. It was said that hospitals hide errors that kill injured patients. It's been published because of the concern on how the victim has been quite a lot in the era of the healthcare services. Do you know why injured patients or sometimes kill patients? First, I would like to introduce you with the real story of the patient was sent to the hospital or admitted to the hospital because of painful in the area of abdomen. When he arrived at the hospital and he was diagnosed as having appendicitis. That's true, but then his wife saying, can we do more than that, or doing other diagnostic procedure? Finally, after a certain diagnostic procedure has been made, and then it was found that there is nothing in the appendix of the patients. He suffered from stone at the urethra. This is what we call misdiagnosis. Painful in the abdomen doesn't always mean that the patient's having appendicitis. I will show you this pie chart showing that when we diagnose patients having appendicitis using physical examination, we will find that 36% are negative appendectomy. So it will be dangerous when you press the McBurney sign and saying to your patients that patients having appendicitis, and you send them for operation, and then 36 will be incorrect. Now, what the new diagnostic procedures is introduced is, for instance, ultrasound. Using ultrasound, it improves the accuracy of diagnosis. However, still remain 9.8% are negative appendectomy, meaning out of 100 patients were diagnosed with ultrasound, about 10% are still misdiagnosis. Well, of course, this is a lot of evidence showing that, sometimes medical error killed patients. From deadly medical errors still common, over 1 in 6 older ER patients wrongly given potentially harmful drugs, etc., and so forth. Well, it may be easier to show this graph. By the time you improve your knowledge or your skill, and then your clinical skills improve, especially those who are senior, then more skillful than those junior. But then, at the same time, for instance, because clinicians are busy with their patients, they don't have enough time to read journals or whatsoever. And finally, he lost the new evidence or current-based evidence. At the same time, medical error increased. What does that mean? Some clinicians may do the clinical practice which was all right or okay in the past, but then new evidence showing that his practice is no longer recommended. It is why medical error happened. I'll give you an example for this. In the past, for instance, if we see children with fever And then the mother will always give a spong, tepid spong, which is cold water, to reduce the fever. It was all right at that time, but no longer recommended right now, because you should use warm water to reduce the fever. And then in the past, when we detect fetal heart rate, we use a Linac stethoscope. Right now, we use Doppler, etc., and so forth. A good lesson can be seen from this slide. Let me show you the story of drug which we call rofecoxib. In 2000, it was published in New England Journal of Medicine, very high-rank journals, medical journals, that the study showed the risk of GI bleeding is much lower than NSAID. As we all know, rofecoxib is COX-2 inhibitors. It was proposed to be better than non-steroidal anti-inflammatory drugs, because the problem of NSAID or non-steroidal anti-inflammatory drug is gastric bleeding. Well, this drug was introduced to reduce the risk of gastric bleeding. In 2001, it was published in Circulation. It's a good journal, cardiology journals. The study involved more than 28,000 patients. It was also shown that the risk of cardiovascular disease is similar to NSAID. It was clear at that time that, COX-2 inhibitor didn't increase the risk of cardiovascular disease. However, 2 years after, which is 2002, it was published again in Lancet, involving more than 200,000 patients. It was shown that the risk of coronary heart disease at a dose of more than 25 milligrams increased. And finally, in the 2004, it was published in Lancet. It was called that a risk of congestive heart failure is 2.5 times greater than NSAID. In 2004, this drug was withdrawn from the market all over the world. So it shows us that evidence comes and change the past evidence and showing a better decision not to prescribe rofecoxib. It is known that medicine and all other healthcare areas are rapidly changing. We can see easily, if you go to the library, you will see so many journals available. Today is more than 21,000 medical journals are available. You can easily get access, but you don't have a chance to read them all. And then, as clinicians, we should base our decisions on evidence. Second, why EPM? Our daily need for valid information about diagnosis, treatment, prognosis, etc. are unavoidable. And then if we only read textbooks, and then we will find a problem of, some of the reference in the textbooks has been obsolete, because usually they use the last 5 years paper or 10 years paper. From this slide, you will see that, every day we have more than 5,000 new papers in journals, and you don't have time to read them all. Now, what's the problem? Some of the publications can be detected as bringing bias and confounding, and we have to be careful to interpret the result of every study to make sure that no bias and confounding are detected. So, is keeping up to date mission impossible? This is the evolution of human. We start from the left picture to the right. I don't know whether you are in the middle or in the right. I'm sure should be far right, okay? Here in the past, when there was a war and people get injured, they use very simple tools, very simple equipment to help the people. Now it changed to the right picture. In the past, we used linac, such as in the left picture, and now we use stethoscope in the right picture. In the past, midwife always use what we call linac in the left picture, this, and then now this is more accurate equipment, we use Doppler. So the words change very fast, and the new technology may replace the previous technology. It is why one of the experts say that half of what you are taught as medical students will in 10 years have been shown to be wrong. So if you are now learning evidence-based medicine, maybe the next 10 years, almost 50% of them are incorrect because new evidence are coming in. We have old paradigm about evidence. If you ask doctors or clinicians, why doctor, if you have patients with common cold, then you prescribe antibiotics? The answer will be, well, I prescribe antibiotics because they can be cured with antibiotics. When they left my office, they never come back to my office. Means it's cured. Is that correct? No. They may die, or they may go to another hospital. And when we see this, no paradigm saying that, well, if you see the patients and having common cold, and you said to the patients, well, you don't need antibiotics. Why? There is an evidence showing that antibiotics doesn't cure viral infections, in which most of the common cold are caused by viral. So antibiotics is not needed. Now, what is evidence-based medicine? Evidence-based medicine is the consensus, explicit, and judicious use of current best evidence in making clinical decisions about the care of individual patients. Meaning, as a clinician, you have to be very careful in deciding what diagnosis can be made for the patients and what treatment should be given to the patient, and it must be based on available evidence. Evidence-based medicine is supported by three things. First is clinical expertise, second, best research evidence, and third, patient values. Clinical expertise means the more you do a practice, the more skillful you are. But it doesn't mean that you can guarantee what you do is correct. Best research evidence means you check with the current best evidence. Is there any change in the use of technology right now, which is more accurate, and whether the treatment that you prescribe to the patient is the correct one based on current evidence. Patient's values mean patient has the right to say yes or no. Like for instance, when you decide to send the patient to the hospital for the operation, but the patient say, well, I'm afraid to be sent to the hospital right now. So there is such discussion on it. In the past, we do the evidence with DOE, or disease-oriented evidence. Everything must be related to the pathophysiology, pharmacology, etiology. But right now, we move to the POE, or patients-oriented evidence, in which when you decided to give a treatment, it must be considered that, will it improve the quality of life of the patients? If the price of the medicine is very high, will it be reducing the risk of mortality or morbidity of the patients? This is some of the example of DOE and patients-oriented evidence that matters. For instance, when we are talking about lipid-lowering drug, and then in the DOE, it lowers serum cholesterol. That's correct, because it also reduces cardiac events. But the POEM, or patients-oriented evidence that matters, saying, well, if I'm prescribing lipid-lowering drug, it will improve the quality of life of the patients. It reduces the risk of mortality. This is the 5 steps of evidence-based medicine. First, you need to develop your answerable clinical questions, in which at any time you see the patients and then you develop your own clinical questions. And then you're not answering yourself because you efficiently find the best evidence. So you acquire evidence, you search for evidence and find the evidence. After having the evidence, or journals or paper whatsoever, and then you appraise them to make sure that there is no bias, then it's true, the number of sample size is adequate, and it is based on randomized controlled clinical trial. And finally, you need to apply the treatment to the patient based on the evidence that you found in the journals. There are 3 different modes of practice. First, replicating the practice of experts. If you do your internship and then you just see your senior do everything and then you follow them, means replicating the expertise, the practice of experts. It is fast, easy, but the problem we will find, this is ego-based recommendations. Maybe what you see are no longer recommended based on current best evidence. Searching only means it can be fast, and if it is appropriate, and then you will find appropriate evidence base. But then this is the appropriate one, or the proper one. Searching and appraising, you see the evidence-based care from the journals, and then you appraise them, and then decide what treatment should be given to the patient. But this is time-consuming, of course. Now, I'm going to show you very brief about the cycle of evidence-based medicine. See a patient, ask a question, and then seek the best evidence, and then appraise that evidence, apply the evidence, and monitor the change. Clinical questions, or answerable clinical question, can be started with, for instance, converting the need for information into answerable questions. Foreground question is, for instance, we have patients with recurrent stroke. What kind of treatment can be used to treat that patient? That's what we call foreground question. Foreground questions mean you provide questions, but there should be an answer for that questions. The answer should be available in the journals from the research, the result of the research. Second, collect evidence to answer question. Where to search? Are you going to find it in the textbook? I would never recommend if you use textbook for treatment, diagnosis, and prognosis. It may be correct for instance, epidemiology of the disease, etiology of the disease, etc., but not to decide what treatment should be given to the patients. So you need to move to the journals, electronic evidence databases. Number 3, you need to critically appraise the evidence before you use that for decision-making process. You can go to that users guides available and accessible to the website on that slide. And finally, you integrate the critical appraisal that you have done, and then you use that evidence to treat your patients. If it doesn't work, and then you evaluate the effectiveness and find another evidence. Okay, Now, this is the level of evidence that we have to be very careful in defining the evidence. The highest level of evidence is always 1A, which is meta-analysis or systematic review. So if you find paper with the title of meta-analysis or systematic review, especially for randomized controlled clinical trial or systematic review for randomized controlled clinical trial, then you can use that as a reference, as the highest level of evidence, which is 1A, followed with 1B, which is randomized controlled clinical trial. All the evidence must be made based on randomized controlled clinical trial. Level 2A is non-randomized trial. Level 2B is quasi-experimental. Level 3, observational study, such as cohort, case control, cross-sectional study. And level 4, expert opinion or clinical experience. If there is no evidence available in all journals, finally you can ask expert to answer your question. But it doesn't mean that you can rely on the answer of expert opinion, because this is the lowest level of evidence. What about preclinical studies and in vitro study? We cannot use these two kinds of study, which is in the bottom of this slide. Those two cannot be used as an evidence. Okay, let me discuss about asking answerable clinical question. This is the first step of doing evidence-based medicine. What are they? First, we understand the background question and foreground question. Background question means if, for instance, you ask question about what is the etiology of stroke? What are risk factors for developing heart failure? What are the risk factors for lung cancer? All those questions are background questions. It can only be raised by new medical students. But when we do a practice as a clinician, we have to move from the background question to foreground questions. What does foreground question mean? It has to be divided into PICO or PICO. PICO means P is patients, I is intervention, C is comparison, and O is outcome. This, for instance, examples of background question. What are the treatment for dyslipidemia? What are the risk factors for stroke? What is the best treatment for pneumonia? Those are background questions. But then foreground question is, for instance, P is patients or population, I is intervention, C is comparison, and O is outcome. Example of this is in patients with an acute myocardial infarction, are arrhythmic drugs more effective than standard therapy in preventing sudden cardiac death? This statement can be divided into 4 parts. P is, for instance, patients with acute myocardial infarction. I means antiarrhythmic drug, which is intervention that you would like to use for your patients. And C, there should be a comparison. Why you propose using antiarrhythmic drugs? Then there should be comparison. For instance, comparison is standard therapy. And then O means sudden cardiac death, which is the outcome. Means when you are going to decide whether you would like to treat your patients with antiarrhythmic drug, you have to be confident that there is a study comparing your proposed drug to other standard therapy, and make sure that your proposed drug is much better than standard therapy in terms of the evidence or of sudden cardiac death. Every part of the evidence will bring a different story. If we are talking about diagnosis, for instance, in 7-year-old child with sore throat, does clinical findings, this is the intervention. C is compared to culture pharyngeal swab. For instance, you see your patient, 7-year-old, and then having sore throat, and then you will be asking yourself whether I have to send my patients to the hospital for accurate diagnosis, and then you compare clinical finding with culture of pharyngeal swab. What will you see? More sensitive in detecting Streptococcus beta hemolyticus group A, meaning because you suspect your patients having Streptococcus beta hemolyticus group A, and then to detect whether there is Streptococcus, you have to use which one? Clinical findings or pharyngeal swab? Again, with harm and also other part of the examination or the use of evidence-based medicine must be used effectively, carefully, and adequately. Thank you.